I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Sally, good morning. Great to see you.
Morning. What's up with you, Jam? How's your morning going so far? It's 9 o'clock, but a lot can happen before the hours of 9.
A lot can happen, but it's all been good. And I've been looking forward to recording this episode. It's going to follow on from what we talked about last week. So today we're going to talk about initial therapy for patients who are strong and fit enough for a stem cell transplant. So what we call induction chemotherapy. And there's quite a lot of standardization, really, in terms of what we give in this sort of situation, Sally. So what's the broad scenario? How do we treat people? And then we'll talk about the drugs in some detail.
It's fair to say that this landscape, in terms of what we offer people, has evolved with time, and it's fortunately continuing to improve. But as we discussed in our last podcast, transplants have been around for a long time. But what's changed recently, and by recently I mean in the last few years, is that the drugs we can give before transplant, and importantly as well after transplant now, work better. They work better in more people and hopefully with very manageable side effects. What we're going to explore today is that combination of drugs that we're currently able to prescribe, and maybe we'll spend a little bit of time at the end talking about what the future might look like as well. We're talking about what we call a regimen, which is a group of drugs that we give together for people who are going forward to a transplant. And we refer to the current regimen that's available in the UK as DVTD. And each letter stands for a different drug. So there's 4 drugs in that combination, and I'll talk through them in turn. So the D is daratumumab. The V is actually a drug that we call Velcade, but it also goes by the name of bortezomib. The T is thalidomide, and the D is dexamethasone, a steroid. So perhaps we can have a chat about how those drugs are given and the side effects and what that means in the round. So I think that's our standard practice, isn't it? Everywhere really in the UK. I think most people going for a transplant get that regimen.
They do, and it's normally given for 16 weeks. Now, there's this concept of a cycle when people give chemotherapy. It can be a bit of a vague term, but what that means is that it's a group of drugs that's given for a defined period of time, and then you repeat it again. It's a little bit arbitrary when you decide a cycle ends if actually each week you broadly do similar things. But essentially, it's 4 4-week cycles given for a total of 16 weeks with these 4 drugs that work together synergistically to get on top of the myeloma. Together with the chemotherapy, there's various support medications to stop various things happening like infections and blood clots. And we'll go through those as well because when people start, they're often given a piece of paper or a guide to what drug is given on what days and how it's given, how they take it and what they take with it. And people need that because often people might be on very little medication before they get myeloma. They might have the odd blood pressure medication or a statin or something. And then all of a sudden it's like, bam, you're on all these medications. So it's a lot to take in. And I think we forget that actually taking medication isn't very nice a lot of the time. And there's a lot to remember. So if we start with the chemo drugs, Sally, so let's, I think, just go alongside. So the D, the daratumumab, what is that and how is it given?
Yeah, so daratumumab, which is quite a mouthful in itself, is given to begin with under the skin once a week. So what we call subcutaneous for 8 doses, so that's 8 weeks. And then 8 doses once a fortnight. So that extends it. So initially it's 8 weeks of every week, and then it's 16 weeks of once a fortnight. And then after that, it goes down to once a month. But for the sake of what we're talking about, treatment pre-transplant, which is what we're talking about here, at the beginning, the first 2 cycles, you have it every week. And for the second 2 cycles, you have it every fortnight. Now, daratumumab's an interesting drug in that it's really been responsible for a game change in terms of how we treat myeloma, or this class of drugs, I should say. So if you were to explain daratumumab, I would describe it to somebody as a protein that is is given and into the body, and it makes its way to the myeloma cell and sort of latches on. It targets a myeloma cell. It spots a protein on the outside of the myeloma cell and is able to identify and make that myeloma cell vulnerable to death. So it increases the body's ability to destroy that myeloma cell. And this class of drugs are called monoclonal antibodies. And to begin with, these drugs were initially given into the vein, and we're very blessed now that we can now give them under the skin, which not only is much quicker, but also results in fewer side effects or fewer toxicities when they're first infused. So that's how I describe daratumumab to my patients.
With the daratumumab, Sally, you touched on the side effects. The first time this drug is given, it can cause allergic reactions, which thankfully are very mild now, and people get medications in the forms of tablets to damp down the immune system so people don't get a reaction. And certainly since we've been giving it under the skin, it's very rare for us to see any significant infections, but people tend to be watched on the day unit or the chemotherapy area for a number of hours afterwards just to ensure that they don't get a side effect. The support medication that will go alongside the daratumumab to stop people getting a reaction will be things like paracetamol, an antihistamine, so a drug like Piriton, drugs that are often used in hay fever. And actually for the first 4 doses, in a lot of places, I think in most places, people get a drug called Montelukast, which again is a type of drug that damps down the immune system, which is commonly used in conditions like asthma. So that goes alongside the daratumumab. And then there's one other injection that goes along the skin. So if we move from the D to the V, this drug Velcade, also known as bortezomib, this also goes under the skin, and it's a quicker injection than daratumumab. And this is given every week for a total of 16 doses, ideally. It's much quicker to give. So actually in some units, there is the opportunity to learn how to do it yourself. Therefore, it can be given at home rather than always having to come into hospital for it. This is a drug that has been a class of drug that we've been using for many years and very highly effective in combination with the other drugs that we're talking about.
Velcade, I think we spoke to it in our trials podcast, is an interesting drug in so much that, again, when we first started using it, we gave it into the vein, and when we did that, we saw significant side effects with this treatment. But subsequently, we learned that if you give it under the skin, it works just as well, but the side effects can still occur, but they're just less severe and they're less frequent. And so it's great that we can give it under skin, not least because people can potentially give it to themselves, but also it gets around some of the potential toxicities. And the toxicities in Velcade are important, aren't they, Jam? We do still see it quite a lot.
So one of the major side effects of this drug is neuropathy. And when we talk about neuropathy, we mean damage to the nerves. Nerves are a crucial part of the way our bodies work, and they're nerves that control, of course, muscle function and our ability to sense and blood pressure. And they're so crucial to many of our body's processes that lots of symptoms can happen if you get what we call neuropathy. It can be something just like tingling in the hands or feet, or abnormal sensation maybe when you walk, or you can't quite feel hot and cold correctly. So that's more typically what we call peripheral neuropathy, so nerves that are towards the edges of our body. But it also can affect the nerves that control functions like blood pressure, so people can get dizzy. And certainly when you see your doctors and nurses, they will ask you about the symptoms of neuropathy very often, because the important thing about these symptoms is finding them early and then reducing the doses of drugs like bortezomib or Velcade to try and ensure that it doesn't get worse, because it can be a very problematic and difficult symptom that can last a long time. And we will be doing a whole podcast about neuropathy. But as you say, Sally, we see less of it now. We give the drug under the skin, and we also now give this drug once a week, whereas previously it used to be given twice a week. Other side effects of bortezomib, it can cause bowel symptoms such as diarrhea or even constipation. It can cause nausea, fatigue. Something that can be also problematic, but thankfully it's only in a small proportion of people, can be eye symptoms. It can cause sore eyes and the development of styes in and around the eyelids, which isn't that common, but when it does happen, can be problematic. So lots of things to monitor when we're thinking about Velcade. So we've got to the end of the 2 injections of the D and the V. And now, Sally, we have 2 tablets. So what's the T?
The T is a treasure of a tablet called thalidomide. Now, many of our listeners will be familiar with thalidomide because obviously it has a notoriety. It's famous for a reason because it did cause significant harm to unborn babies when it was given to pregnant women who were feeling sick. I think it was in the 60s. And so this side effect of thalidomide is significant, and therefore when we prescribe thalidomide, we have to fill in a lot of extra paperwork to make sure that no potential fetus or baby is ever exposed to the drug. Unfortunately, in all the years that we've been prescribing, it's decades now actually, I'm not aware of that happening anywhere in the world. But thalidomide was initially prescribed for women during pregnancy when they're feeling sick. So fortunately, if anything, it might confer protection against feeling sick, which is a win. But it does come with other side effects. And the side effects that thalidomide can come with, in particular, are once again neuropathy, slightly similar to Velcade. So adding the 2 together can be a little bit complicated in terms of figuring out which drug to stop if the neuropathy develops. So I think generally what we do now is give a far lower dose of thalidomide than we used to, and we're much more proactive in reducing the dose further, as well as the Velcade if neuropathy occurs. It can cause constipation, which can be pretty problematic in some people actually. And so you do often have to think about, laxatives to keep the bowels moving. So worth flagging about that. It can cause blood clots. And so when you're on thalidomide, you need to often start blood thinners if you're not on them already, because blood clots can potentially be very serious indeed. And you really don't want that to be happening if you're otherwise, in any situation, actually, blood clots need to be taken seriously. So just to reiterate there, neuropathy, blood clots, and of course, let's not forget the harm to unborn babies.
I think sometimes when you tell people you're going to give them thalidomide, their eyes pop out of their head, understandably. The thought that something could have done something so terrible as what happened in the 60s, for it actually to then become actually one of the most transformational medicines in myeloma. It's an older drug now, but still so important. A minority of people, Sally, get a tremor sometimes as well. That's not uncommon with thalidomide. And sometimes when people start as well, people can get a rash. Doesn't happen as much when people are on steroids and all these antihistamines and things, because they do protect people. But if you are getting a tremor and a rash, sometimes we do think thalidomide as well. But it's a very important part of the combination. So we've done the T, and now we've done to the D, our favorite drug. Well, not our favorite drug, but something that we talked about a lot on the pod already, dexamethasone. And steroids, do they make everything work better, Sally? And then they stop side effects? They do, yeah.
They do, I'm afraid. So sorry to all you steroid, congratulations to all you steroid lovers out there who, the steroids give you the lift to enable you to get lots of important things done. But apologies to those of you who don't enjoy them so much. But they are really important because they help all the drugs work better together. And of course, when we see the treatments working well, and we'll be monitoring that according to paraproteins and the light chains and how someone's feeling, we can often reduce the doses of these drugs, particularly the steroids, if they are causing problems. But yeah, so steroids, just to reiterate from our previous podcast, there's quite a list here, so I'm just going to mention it and then signpost everyone else to the steroid podcast, that they can cause indigestion, insomnia, mood change, a sort of hyperactivity when you're taking them. Sometimes people describe it as a mind racing. And then when they've finished, a sort of a depression, low mood, lack of energy. They can affect the muscle strength in particularly the tops of the arms and the tops of the legs, so muscle weakness, and particularly the more that you have them. Fluid retention, so swelling of the ankles in particular, weight gain, diabetes, and even if you don't have diabetes, it may cause you to develop diabetes, or make your diabetic control even harder. Cataracts, particularly with long exposure. Theoretically, they can increase your risk of infections in the mouth, for example, particularly fungal infections, things like oral thrush. They can increase your risk of infections overall.
Just that list highlights why steroid is the drug that will be tweaked most normally in that first 16 weeks. Typically when we start, we give steroids on the day of the injections and the day after, but that can get reduced potentially relatively quickly depending on how people are tolerating the steroids and how they're getting on with the treatment. And that is our DVTD combination. Let's just talk a little bit more about side effects of all of them together, Sally, because clearly we think about neuropathy a lot because when you add thalidomide and bortezomib, they both cause neuropathy. So that's something that we do think about a lot. But people often ask with any chemotherapy when they're starting, will I feel sick? Will I feel nausea and get vomiting, bowel symptoms, diarrhea? Because that's something understandably that people are afraid of. Will I lose my hair? Again, it's another one that we understandably get asked a lot. And what's my risk of infection? So can we go through those, please?
So will I feel sick? Briefly, no, hopefully, particularly
it's
because
good,
of thalidomide.
Right? Yeah, yes. People generally, it's a combination of thalidomide and dexamethasone. People don't tend to feel sick with this combination of drugs, which is great.
Yeah, that's merciful, isn't it? There's enough else going on to not have to contend with that. If you get completely constipated, with a thalidomide or the Velcade, I guess that might affect your appetite, but generally we don't experience sickness. In terms of the hair loss, no, generally not. Occasionally people report hair thinning, but most people don't. And if you were to get hair loss, just a little bit of good news for everyone listening, that's coming later with the transplant, but it's not part of the induction treatment. So that doesn't occur during these first sort of 16 weeks. And then the most important thing to emphasise really about the infection point is myeloma itself, particularly untreated myeloma, increases your risk of infection. So arguably your greatest risk of infection is actually before you have treatment, because that's when the myeloma is out of control and it's suppressing or it's limiting your body's natural ability to fight infection. However, the treatment can affect your blood counts because it needs to clear out the myeloma from your bone marrow. And in doing so, your blood counts can fall. In particular, the cells which you need to fight bacterial infection and viral infections. So yes, when we consent people for treatment, so we talk them through it and ask them to sign a form, we talk to them about infections. That risk is always there. But we also prescribe frequently antibiotics and antivirals, which will confer some protection in the event of an infection. We also, more often than not, give them phone numbers of people to reach out to day or night should they feel like they're coming down with infection or developing a temperature. So there's a safety net there if that was to develop. So yes, infections can occur. I think it's relatively unusual for people to need to come to hospital and stay in hospital with an infection during induction. But it can occur. I've certainly seen it, but it's just not a common event. But yes, you might get coughs and colds, but don't be afraid of that. The most important thing is to take the treatment to help your immune system get better in the long run to maintain your overall health.
The risk of being hospitalised with an infection is actually pretty low, which is really good. And it's probably in the region of around maybe 10%. But Sally, you touched on some important points, and I think now is a good time to cover these things. We've talked about the 4 chemo drug combination, 2 injections and 2 tablets. Alongside that, there'll be the support medications. So there's medication to prevent infections. So we typically give 1 or 2. So what are they?
Typically, we give a drug called acyclovir, and that can help confer protection against viral infections, especially actually because Velcade, let's call it Velcade for the sake of the podcast, can increase your risk of particular viral infections. That's very important. And then we often give a drug called cotrimoxazole, which also has another name, Septrin, just to confuse matters further, which you take on particular days of the week. Generally, it's Monday, Wednesday and Friday, and that can confer protection against a particular type of lung infection. And then most centres can also give a third antibiotic called levofloxacin for the first 12 weeks of treatment, which just helps that whole infection piece overall. And that's based on a clinical study that was done in the UK here some years ago.
In some places, you may also be given a drug called fluconazole, which reduces the chance of getting thrush, which is typically associated with steroids. I have to say I don't give fluconazole to my patients because We see very little thrush when steroids are given the way we give them, but I think that's an optional extra. We give a tablet to protect the stomach because people can certainly notice indigestion or acidity when they're on chemotherapy, and especially it's a side effect of the steroids. And Sally, you mentioned the risk of blood clots associated with drugs like thalidomide. We always give a medication to thin the blood, which is either aspirin or more typically a drug called apixaban, which thins the blood in a different way, but a little bit more. And of course, every 4 weeks as well, people will have a bone strengthening injection as well. So that is the suite of the supportive medications that go alongside the 4 chemo drugs.
Just to add in, of course, as we spoke in our previous podcast, with the bone strengtheners, you're often also given calcium. I mean, I was listening to someone the other day talking about their experience of myeloma and entering into a transplant, and they described leaving the hospital, or I think maybe it was their clinic appointment, with 2 great big bags of tablets. I mean, it is quite an undertaking. I think it's really important for us to share, though, that these tablets are there for a reason, and really importantly, as time goes by, we whittle away at them. We stop them where we can, we reduce them, we modify the treatment. So they're not necessarily all those tablets forever, but yes, it is a lot to begin with. Oh, and I've forgotten one more, Jam, actually, and that's allopurinol. I don't know if you give that, but this is a tablet that some of our listeners might be familiar with because it can be used for gout. And we often give it for the first few weeks, perhaps, of treatment. Sometimes it's the first week, sometimes it's the first month, because it can confer some protection against the kidneys slowing down, particularly if there's a lot of myeloma for the drugs to tackle. So that's a syndrome called tumour lysis syndrome. Now, I must say, tumour lysis syndrome in myeloma is a pretty rare event, but nonetheless, this tablet does tend to appear in most of the bags of our patients leaving hospital, just in case they were to develop that complication.
People tend to give it for maybe a week or 2, and we do use it at the beginning, just to touch on side effects of support medications as well, because of course we've talked about the side effects of chemo, but support medications annoyingly can have side effects as well. And one that very much comes to my mind is rash. So we've talked about the rash that you can get with thalidomide, but drugs like allopurinol and Septrin also are very typically known to cause a drug rash. So you start 3 drugs together, and then sometimes before you know it, you have a rash and you're trying to unpick what the culprit is. So it can unfortunately be a little bit difficult. And if you're there in front of your doctor, and I think whatever side effect you have, we've just gone through probably about 10 medications that you're going to be on. And I think it really does take time, especially towards the beginning where everything is new. If you're getting side effects, it's really something that can be unpicked by understanding how all the different drugs work and what their typical side effect profiles are.
Absolutely, understanding what they're for and what might be the culprit. But your team around you as well, the team that you're seeing in clinic, will help unpick all of that as well.
Sally, and a really important question is, well, how well is this going to work? Broadly, what we say is most people respond to these drugs. And by response, we mean the symptoms of myeloma improving and protein levels reducing, often quite rapidly. It's something that we see. Now we use a 4-drug combination, which is so heartening. Very few things are as nice as showing patients the graphs where you say, this is where your protein was and this is where it is now, and look how well it's responded. So most people do respond. The good thing is of course we can monitor your bloods regularly to understand that response.
I feel very privileged that we can prescribe this treatment and have the confidence to know that in most people it will work. It's also really important to say is the message there is the treatment is highly likely to work. And so you shouldn't necessarily need to suffer to achieve a response. So if you are getting side effects, please let your teams know so that they can adjust the treatment to keep you on the treatment to work as effectively as possible, but also to make sure that the treatment works, but you're coping with it. So please don't feel like you need to tolerate this, stick up with it at all costs to get a response. That's not necessarily the case. We can modify the treatment so that it's still manageable, and hopefully it's not too difficult a time for you.
And it's so common for people to say, if I don't give the medication exactly how it was intended, it won't work as well. And we know that's not true. And it's much more important in lots of situations to make sure that you can keep giving the drugs regularly in doses that are tolerable. And all chemotherapy drugs can either be reduced or omitted and restarted depending on the scenario that evolves over time.
Really important. And I just want to pick up on something you said earlier, Jam, and just to really emphasise this point as well, because I think it is so important. And that's in terms of the neuropathy. So I think neuropathy is a relatively common event. Most people are experiencing it to some extent. But the really important thing is if you don't let us know and you carry on regardless, it's very likely to progress. And often it continues to progress even after we've stopped the treatment. And so actually let us know early so we can modify early. So there isn't this surprise waiting down the line and you think, oh, I've just got one more cycle to go. I can cope with it for another few weeks. Because even after it's stopped, it might get worse. And that's a great shame because what we want is, first of all, for people to not get neuropathy, but if they do, for it to be mild and then in the long term, go away completely. But if it is severe, sometimes people then are left with it in the sort of longer term, and we really don't want that to happen.
I mean, about 60% of people are going to get some sort of neuropathy with this combination of drugs. But thankfully, only a small minority of those, it's very severe. But it's more likely to be severe if, in a way, we find out about it too late. And having to reduce the dose of Velcade is something that we have to do so often because of neuropathy.
Yeah, very, very, very common. So if that has happened to you, is going to happen to you, you're not alone. Know that actually it's unusual almost to stay on the full dose.
Right, Sally, we've talked about DVTD, but in an ideal world, we'd like to be giving something similar, but slightly different, right? Which is now much more of a global standard of care if you can access a 4-drug combination.
And that is, it's all in the letters here, guys.
All in the letters. We love our alphabet.
Oh, yeah. Don't we just? So this is DVRD. So the R has, the T has been switched for an R. And what that basically means is the T, thalidomide, has been switched over for something that is actually, confusingly, in this case, the R stands for Revlimid, but we call it lenalidomide, just to make matters more complicated. But lenalidomide is what we call the next generation thalidomide. It works in a similar way to thalidomide, so therefore it has similar side effects, but it works perhaps better and maybe with fewer toxicities. So it's an improvement on the original thalidomide drug.
And it's given slightly differently. There's many more doses that can be given for lenalidomide, and you have it for 3 weeks and then you have a week off. The typical side effects of lenalidomide are different to thalidomide. Thankfully, it doesn't really cause significant neuropathy. That's not one of the major side effects of lenalidomide. But if you are on DVRD, the lenalidomide side effects that you may experience, or certainly we would need to ask you about, are things like cramps, which can be very common. Diarrhea can happen, but it tends to happen actually after people have been on it for a longer period of time rather than immediately. It can also cause fatigue and drop the blood counts a little bit. And as the thalidomide, when you combine the drugs together, there is a risk of infection as well. But it is better tolerated than thalidomide. There is no doubt about that. And it does look like that when you swap out the thalidomide for the lenalidomide, you're getting a combination that works even better than DVTD. And the hope is that certainly within the UK, that we'll be able to access this combination maybe at some point within the next 12 months.
We await that. We very much would support that coming through for our patients, and we think everyone would stand to benefit. Can I just mention another side effect of lenalidomide, which can be pretty problematic, and that's a rash. So as you said earlier, Jam, lots of the tablets can cause a rash, but lenalidomide can also do that, and it can be a bit of a fiddle, kind of, again, figuring out the culprit drug. And then if it does occur, sometimes you need to pause the lenalidomide, wait for the rash to get better, start it again at a low dose. But more often than not, even if you get a rash, you can eventually go back on it and be rash free thereafter. But that can occur.
Yeah, and like thalidomide, it does also increase the risk of blood clots. So that support medication to thin the blood is also given with the lenalidomide. Again, if you have DVRD, you're given broadly 16 weeks of treatment. And just to remind our listeners, after the initial 16 weeks, then you move into the stem cell mobilization and transplant. But after that, the drugs that we've been just talking about, you get them again for 2 cycles. So that's 8 weeks. And the drugs are broadly given in exactly the same way. And rather than induction, that's called consolidation.
Exactly. And by then you've been around the houses with the drugs, so you know what you're in for, and you can inform us, so your prescribing team, as to, what you may or may not want to tweak and what works best for you. So, it's definitely a conversation. By then you are definitely the expert. So Jam, when we see people in clinic, what we tend to do is say, this is what we want to give to you. This is how well it might work. Here's some information. And that information is rather like our trials podcast, a load of paperwork to read through, which can be pretty overwhelming. So what I tend to do is, at that same time, as well as saying, go away, have a read, come back soon and we'll get things started, is say, look, there's the paperwork to read, but this is what you're most likely to experience. And for that, I just want to share that with my listeners, and maybe you can do the same and see if we differ. The daratumumab, I say, this is no big deal. We'll monitor you first time round. You're unlikely to get a reaction, but if it does occur, it's easy to treat. That's it. Maybe it's inconvenient coming up every week and then every fortnight. The Velcade, definitely look out for the neuropathy. That's the main problem with the Velcade. And aside from that, we'll monitor your blood counts. The thalidomide, you need to be on a blood thinner. That's incredibly important. You watch out for constipation. Let us know if that occurs. And of course, again, let us know about neuropathy. Incredibly important. And then, of course, I reiterate the fact that you have to be very careful in terms of not exposing any potential unborn baby to that drug. So that means going through all the paperwork about who somebody may or may not be choosing to have sex with, whether they can or can't get pregnant, what kind of contraception they might be using. And then I go on to my joyous steroid list. And for that, I say, if you're diabetic, I'm going to keep a closer eye on you, and I'm going to liaise with your diabetic nurse. Watch out. You might struggle with sleep. Watch out for your mood. And you must take your indigestion tablets. And then I hope that what they can then go away with is more manageable kind of reality of what could occur when they start that treatment.
That's amazing, because I'm now never going to talk to a patient ever again, because I'm basically going to rewind this podcast a minute and just say, I could talk to you, but why don't you listen to my friend, Dr. Sally Moore?
Too kind, John.
And we'll just sit there. I'll do some Sudoku in the corner, or we'll make everyone a cup of tea.
Oh, nice.
And your voice in Oxford, which we miss, will be heard again.
No.
But no, in all seriousness, that's such a lovely summary. Paperwork is onerous and can be very overwhelming, and I think summarizing it like that is so helpful. And I mean, genuinely, part of the reason we're doing this podcast also is to provide the information in an audio format with all seriousness. So hopefully this will be an additional use. But I think honing in on the key side effects, and I think we said neuropathy a number of times, but absolutely, myeloma treatment has got so good now that we should be thinking about, well, in 5 years' time, I don't want you to be there grumbling about neuropathy, because it's such an impact on so many aspects of day-to-day quality of life. And we've seen it for so many years. So sometimes when clinics get busy, you may not get asked about all your side effects, but please volunteer information and also go with a checklist to your doctor. It's like, this is what we need to talk about each time. Am I on the right drugs at the right doses? Am I responding to treatment? These are my side effects. Do I need to change anything, or do we just carry on as we are? And that really acts as a good scaffold, I think, for successful myeloma treatment in general, but definitely for induction myeloma therapy.
Totally agree. This is all about getting that person as fit as possible, and that's what we're here to help with. So yeah, agree entirely.
Sal, it's been a really good discussion on induction chemotherapy for our younger, stronger, fitter patients. And we're going to follow this with the next podcast, where we talk about our patients who are not going to have a stem cell transplant and what initial treatment looks like for them.
Thanks, I'm really looking forward to it, and keep in touch, everybody.
See you soon, everyone.
Bye.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed. and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.